Hello, and welcome to this virtual program on multiple sclerosis. This is an introduction uh, to multiple sclerosis, especially for patients that are recently diagnosed, but also maybe a nice review for patients who have had established diagnosis of MS, or this may be very helpful for friends and family who are living or know someone with multiple sclerosis as well. This event is being recorded on April 28th at the Providence MS Center in Portland, Oregon. So once again, thanks for joining me today. So many people ask me why I'm interested in multiple sclerosis or how I became involved in multiple sclerosis. And first of all, my mother was diagnosed with multiple sclerosis during my first year of medical school. And obviously, this was quite a shock and very concerning since we had a neighbor when I was growing up who had multiple sclerosis who was in a wheelchair. And so, of course, I was quite frightened by that my mom had MS and very concerned about her prognosis. And this is a picture that was taken a few years ago when we were on vacation together, and she is doing quite well. And since she was diagnosed, she was started on treatment right away and has not had any relapses or progression of her disease since that time, which was over 20 years ago. So while this is fantastic, this is also not uncommon, as now that we have many treatments for multiple sclerosis, patients tend to do quite well. So I would like to discuss the objectives for the program. So we're just going to give an overview of multiple sclerosis, talk about some of the symptoms that can occur in MS patients. And there are different types or phases of MS, which we will review. Talk about how the diagnosis is made. As many of you know, there's not one specific test that can confirm a diagnosis of MS. It's usually compiling information, including the history and MRI findings. And then we'll talk about treatment for symptoms, specifically for relapse, and give an overview on disease-modifying therapy. I'm not going to go into them in too much detail. That's a separate talk in itself, especially since the number of options have expanded quite a bit in the last few years. We'll also focus on MS wellness, and then just briefly talk about what is on the horizon, particularly medications that potentially might help with repair or improving symptoms. So unfortunately, MS is a chronic disorder. We do not have a cure for multiple sclerosis, and it commonly affects three parts of the nervous system: the optic nerves, and it's common for MS patients to present with something called optic neuritis, where patients can develop a loss of vision that typically develops over the course of several hours or maybe a couple days, and is associated with pain with eye movement. Unfortunately, most patients recover quickly after their first episode of optic neuritis and maybe have a slight residual visual loss or maybe none. It also can affect the brain and then parts of the spinal cord, specifically the cervical spine, which is the portion in the neck, and below the cervical spine, which is the thoracic spine. MS does not affect the lumbar spine, so that's a common question that comes up. Why do we not image the lumbar spine? The spinal cord actually ends at the lower part of the thoracic spine, or the top of the lumbar spine. So in the lumbar spine, there are only nerve roots, and so MS does not affect nerve roots. It's just going to affect potentially the spinal cord itself. Most patients actually do not become severely disabled with MS. So obviously that's a concern, and rightfully a concern for people that are initially diagnosed, given the uncertainty of the disease. But again, with disease-modifying therapy, we've had a significant positive impact in reducing disability and relapses associated with this disorder. MS is a disorder where the immune system is overactive and fits in a category of an autoimmune disorder. And there are many other autoimmune disorders, including rheumatoid arthritis, lupus, Crohn's disease, and some thyroid disorders are also autoimmune. Unfortunately, again, we don't know what causes these type of disorders, but a subset of the immune cells are overactive, and depending on the disorder, they're then attacking, let's say, an MS, the brain or the spinal cord, as well as the optic nerve, because they feel that part of the body is something foreign that needs to be cleared. And what happens in MS is that there's inflammation that occurs, and that leaves scars, which we can see on the MRI as white spots or lesions. And the word sclerosis means scar. On the right of this slide are two pictures of looking at our nerves under an electronic microscope. And you can see in between the arrows here is an area of green where there has been loss of myelin. And to the right here, this is sort of a normal part of the nerve. The yellow is the axon, which transmits the signal, and the outer part, the red, is the myelin, which protects the nerve. And this is just showing areas where there has been loss of the myelin. And sometimes when the inflammation is severe, then you can get damage to the axon. And then what happens is you get swelling of the nerve, and you can see that better down here at the bottom, where you have sort of this enlargement of the neurons, which is where the axon begins. So this slide, there's a lot going on in this slide, and I showed it for a couple reasons. One, to just sort of point out that the immune system is quite complicated. And two is just to give you a little bit of a background of what potentially may be occurring in MS, and where maybe some of our medications that we have for treatment may be beneficial. So on the left here are your white cells, and specifically a subset of your white cells called lymphocytes, which are circulating in the blood. And we have different white cell lymphocytes, which include T cells and B cells, and they interact together. And again, these are extremely important. Without these cells, we would be more prone to infection. They also provide some surveillance in terms of helping prevent the development of cancer as well. And you need to have some cells cross over from the blood into the brain to just help, again, to provide some surveillance. But in MS patients, potentially more of those cells cross over. And again, some of those cells have been misguided. And so then they start to attack the outer part of the nerve, the myelin, and then also potentially the axon. So you can see on the right here is a healthy neuron, and it's estimated that we have roughly 100 billion of those neurons in the brain. And then that gives rise to an axon, which is the lighter green. And this darker green is the myelin, again, which protects the nerve. It also allows the electrical signal to travel much faster down the nerve. And there are certain cells that make the myelin called oligodendrocytes. And so it's possible in MS patients that those may not work as well. And so there are lots of studies trying to figure out how to turn those cells on to regenerate the myelin. And then you can see on the far right is a small picture of a neuron. And again, you can see parts of the myelin that are missing. So they've been chewed away by the immune cells. And again, when there's lots of that type of damage occurring, then that can result in neurological symptoms. So we have lots of medications that can target different parts of the immune system. We have a medication called natalizumab, which helps prevent cells from crossing over from the blood into the brain. We have medications that specifically focus on these B cells, and that would include ocrelizumab or ofatumumab. And then we also have medications which sort of alter some of the T cells and sort of shift them to do what they're supposed to be doing and fighting off infection. And those would be medications in the interferon category or the glutaric acetate category. And those are just a few examples. So the prevalence of MS is quite high in the United States, although as we'll talk about in the next couple of slides, it's a disorder that affects people worldwide. And a recent study in conjunction with the National MS Society indicated that over 900,000 people probably live with multiple sclerosis, and this is twice as much as what was previously reported. And then you can see on the right that over certain time periods, the number of people per 1,000 US residents has increased significantly, at least since 1976. And again, there are many reasons for this. Now we're able to capture data much more easily, and a lot of health systems are using electronic medical records, which allows us to capture this data. Obviously, it's easier to make a diagnosis of MS since MRI is readily available, which obviously was not available in the 1970s or 1980s. So yes, the numbers seem to be going up quite a bit, and actually they are. There's estimate that autoimmune disorders have increased by 10 to 20% even in the last 8 to 10 years, and also more awareness. So with the internet and social media, people are more aware of MS and have an understanding of MS. So if they're having symptoms that may be similar to MS, they're more likely to go see their doctor and to be evaluated. So who typically develops MS? Really anyone can. So children can develop MS. Sometimes we see patients in their 70s that are diagnosed with MS, although that's quite rare. And usually those patients have a history of previous symptoms that either a patient ignored because they went away, or maybe they were attributed to something else, maybe due to a migraine or a stroke. So we do see that, but we're always cautious about making a diagnosis, especially when someone's 60 or older. But the average age of diagnosis is usually in the mid to early 30s. Women are much more likely to develop multiple sclerosis, and that's really the case with most autoimmune disorders. And that ratio potentially has expanded over time. And there are some places in the world where that ratio is even greater. And the exact reason for that remains unclear, but a little bit later I'll talk about genetics, and potentially that may play some role in why there's that discrepancy. Caucasians are more likely to develop multiple sclerosis, although there is some data, especially out of a study from Southern California, that that's not the case, that potentially Blacks or African Americans have a higher risk of developing MS. And we are part of a national African American registry. Dr. Cohan was one of the lead proponents of establishing this registry, and this is throughout the United States. So for anyone that is Black or African American, I encourage you to go to this website and register. This allows us to follow patients more closely and sort of identify the care that they're receiving. There is some concern that potentially Blacks or African Americans may have a more severe course of MS than Caucasians, and the exact reason for this remains unclear, but this registry potentially might be helpful in answering some of those questions. Geographic distribution. So interestingly, MS is more common in the northern part of the United States, and also in Canada, and also in northern Europe. And why that's the case is a little bit unclear, but we'll talk about that in some subsequent slides. So looking at a map of the world, this just sort of indicates where there's a higher prevalence of MS. You can go to the website in the bottom, and it has all kinds of maps and statistics about multiple sclerosis, which you might find very interesting. But as you can see, MS is much more prevalent in North America and Europe. And then Australia and New Zealand also have a relatively high prevalence of multiple sclerosis. Again, you look at the southern hemisphere and around the equator, obviously different genetics, different backgrounds, so environmental risk factors may be also different. So this is why you may see some discrepancy. So what are the potential triggers or causes for MS? And I'll walk through really each of these categories. So one, genetics may play a role, but it's likely not the sole explanation for developing multiple sclerosis. There may be some environmental factors, and we'll specifically talk about vitamin D. And then there may also be an infection that one is maybe exposed to that maybe ramps up the immune system that may put it in overdrive. And the leading theory is possibly Epstein-Barr virus. So you almost really need all three of these risk factors to develop MS. So it's sort of like everything coming together like a thunderstorm. But again, it's still unclear what possibly triggers this. So in terms of looking at genetics, MS is not directly inherited. So if you remember your high school biology, there's autosomal dominant disorders where if your parent has a certain disorder, then you're at risk of developing that roughly 50%, or maybe an autosomal recessive disorder, and that risk is roughly 25%. And MS does not fit in either one of those categories. But again, it's maybe a combination of genes that contribute to the development of MS and other autoimmune disorders. So it's not uncommon to hear families, if I see a patient who has MS, that commonly they have other family history of other autoimmune disorders such as Crohn's disease or lupus or rheumatoid arthritis. There's an international MS genetics consortium, and they've been able to identify quite a bit of variance in the human genome, which puts one at risk for developing multiple sclerosis. And obviously, there's a lot that we need to learn about genetics, and I'm sure that we'll hear about more of this in the future. But there is some thought that a generic variant for MS is more prominent on the X chromosome, and women have two X chromosomes while men only have one. And so maybe this may be one reason why MS is more prevalent in women compared to men. It's estimated that the overall risk of developing MS is about 1 in 330, which seems to be relatively high. But your risk increases if you have a family member. So for me, I guess my risk would be about 1 in 67. And if you have a sibling, that risk really almost doubles to about 1 in 37. So it's very common for patients to ask me about who are newly diagnosed, what about their children, or should they even have children? And the recommendation is to move forward with family planning, and the relative risk is quite low. We do know that there are some potential risk factors for people developing or kids developing multiple sclerosis, and one is obesity, and also the other one is low vitamin D levels, which we'll discuss here shortly. Potentially also exposure to secondhand smoke may also be a risk factor for children who may develop MS at a later age. So there are some things that can be done to help reduce that risk, but in reality, who knows how much those things play a role in the future development of the disease. Epstein-Barr virus, and there's a lot of research right now looking at the role of Epstein-Barr virus. And the problem is that the vast majority of people have been exposed to the Epstein-Barr virus. So roughly 95% of us have been exposed to Epstein-Barr virus. But if you also check this in Epstein-Barr virus previous exposure in MS patients, it's almost really 100%. MS patients that have had mono are also at a little bit higher risk of developing, patients that develop mono are higher risk of developing multiple sclerosis. And then again, current or previous smokers who have been exposed to Epstein-Barr virus, again, are more likely to develop MS as well. Vitamin D, there are several studies suggest that low vitamin D levels may increase one's risk for developing multiple sclerosis. And there was a nice study that was conducted on individuals that were enlisting in the military, where they checked, where they stored blood samples, and they were able to identify people that enlisted with low vitamin D levels were more likely to develop MS while they're in the service. And there have been other studies that have shown similar results, that these low levels increase one's risk. And there are several studies that suggest that potentially vitamin D may also be helpful for MS patients in terms of reducing relapses and MRI changes. Some of the studies are mixed. There has been some studies that have not shown any benefit, but there are ongoing studies looking at this further. So in my practice, I like to check vitamin D levels at least once a year. And for some patients that have low levels, and may repeat a level 6 months after making a change. And the key is to remember that vitamin D is a fat-soluble vitamin, so you can overdose on vitamin D, which potentially can cause kidney stones and inflammation in the liver. This is different than vitamin B or vitamin C, which is a water-soluble vitamin. Those, if you take too much, you just pee it out. So it's important to make sure you discuss with your clinician the appropriate dose of vitamin D. Living in the Pacific Northwest, we have a lot of cloudy days. Even if it's sunny in the winter, we're quite far from the equator, so the UV index is quite low, and you need the UV radiation to activate the vitamin D in your skin. So yes, probably vitamin D levels do go up in the summer if one is outside, but usually not enough to make significant alterations in vitamin D dosing. Again, that may be one reason, again, why MS is more prevalent in the Pacific Northwest, is partially due to the weather that we experience here. So the symptoms with MS can be quite variable, and a lot of that's going to depend on where the inflammation occurs. And so for some patients, and actually quite a few patients, may present with optic neuritis, which I mentioned earlier is associated with loss of vision and obviously quite scary, but actually usually has good prognosis. Sometimes inflammation can occur in the spine, which we call transverse myelitis, and that can be associated with weakness, loss of feeling, possibly a change in bowel or bladder function. And these symptoms may come and go, and especially if one is younger and maybe presenting with their first relapse, a lot of times they will resolve typically after a few weeks, but sometimes after a few months. But if one continues to have relapses, then likely there's going to be some residual symptoms after relapse. And a relapse is typically something that's new. Patients not experienced the symptoms before, and usually the symptoms are going to last at least 24 hours, but to be honest, most of the time they're going to last several days or weeks. So if you wake up and maybe your left foot is numb, but it goes away after an hour, it may just be due to how you slept, maybe compressing a nerve. However, over the course of the day, if that numbness starts to creep up into the leg and maybe up into your torso, then that would be very concerning that there is something new that's occurring. And it's very important for you to make sure that you let your doctor or clinician know. MS symptoms can come and go, and that can be obviously very frustrating. Sometimes you can identify a trigger for the increase in MS symptoms. A lot of times, if you maybe have not slept well or you're more stressed, that can increase the MS symptoms. And one factor that can also increase symptoms is an increase in body temperature. So when the body temperature goes up, the electrical signal disperses more, and so then the body has to work harder to transmit the signal from the brain, let's say, down to your left foot. And so if it's not able to do that, then that's maybe when you may notice some numbness or tingling, or maybe some weakness of that foot. But once your body temperature cools back down, then the symptoms should resolve. You're not creating a new lesion. The lesion isn't getting bigger. But it's important to realize that maybe heat may potentially play some role. And so some patients don't like to be out on hot days because of this. or some patients that their exercise is limited because increase in symptoms. So for exercise, which is very important, maybe starting off cooler, wearing less layers potentially might be beneficial. So on the right is quite a long list of potential symptoms. That does not mean that all these are going to occur in one's course of MS. The three that I do want to spend a little bit of time talking about are problems with memory or cognition, which can occur in about 40 to 60% of MS patients, and most patients find the symptom to be more annoying, but sometimes it can be more involved and may interfere with work. And again, it's important to let your clinician know if you're having those difficulties, and likely they may want you to have more testing. So neuropsychological testing can be quite beneficial to identify where you're having problems and then provide some feedback. Now, there are other things that might contribute to memory issues, including depression. Memory issues can be a symptom of depression. Sometimes medications can also contribute to cognitive or memory issues. And then sleep is extremely important. So for many MS patients, insomnia is common, and that may be due to having pain or maybe muscle spasms. For some patients, they have to get up frequently to go to the restroom. And so there are things that can be done to help improve sleep, which in turn obviously will help with your memory, specifically attention and concentration. Fatigue is also a common MS symptom, and maybe the most common. 90% of MS patients report some fatigue. And typically, MS fatigue, patients feel fine and well rested when they get up, but later in the morning or early in the afternoon, they really hit a wall. And sometimes just taking a nap, maybe 15, 20 minutes, they're able to recharge and they're able to continue with whatever they were doing beforehand. So sometimes just learning to adapt and really trying to get as much done as you can in the morning, or what you need to get done, and then sort of save sort of extra stuff in the late morning or afternoon. But obviously it can be very frustrating because it may limit what you want to do. I mean, many patients that continue to work, but for some of those patients, by the time they finish with work, then they don't have a lot of energy to enjoy things in the afternoon, or in the evening with their family. So again, it's going back and sort of looking what are some things that might be contributing to the fatigue, including poor sleep and medication. Depression is common, so maybe 50 to 60% of MS patients will experience depression at some point during the course of their disease. And so it's very important to make sure that your clinician is aware if you're having symptoms of depression. And at our clinic here, we screen for depression. Most of the time, patients are seen in the clinic. So there are different courses of multiple sclerosis, and really there are three main courses or types of MS, with relapsing or remitting being the most common. And it's possible that patients that start with a relapsing remitting phase may transition to the secondary progressive phase. And that used to be about 50% of patients 10 years after the diagnosis would transition into this phase, although that was prior to prior to treatment for relapsing MS. And so that number may be roughly 10 to 20%. And then primary progressive is approximately 10% of patients, and those patients do not have any previous history of relapses. They typically just have a slow progression of their disease, and I'll walk you through the progressive types here, and then on the subsequent slides. So on the right here is an example of a course, relapsing remitting course, with patients that's likely not on treatment for MS. So you can see the orange would represent where a patient has had a relapse, and you can see that the patient did quite well and has returned back to their baseline, and they're not having any clinical worsening, but maybe they're having some MRI changes, which is identified with the purple arrow here. And that's why we like to get MRIs periodically, because one can develop new lesions and not have any new symptoms. And then you can see with the second relapse, the patient did not have a complete recovery. And then another relapse, a third relapse, they're sort of, again, left with more disability related to their disease. So when we see patients, obviously we're going to see them in this first phase, and we want to then get them on treatment and prevent any further episodes or relapses. And these are two examples, one secondary progressive MS on the left and then primary progressive on the right. And again, in the gray would be a course of a relapse, and the patient's left with some disability. And then things slowly get worse over time, and we do start to see some MRI changes, but they don't occur as often. Maybe a patient might have a relapse in that transition, and we call that active secondary progressive MS. But then all of a sudden, things just slowly get worse, and patients may plateau, and then there may be some worsening down the line. But again, it's so variable, and it really just depends on the patient. Again, we want to prevent transition into this phase. What happens in relapsing MS, there's a lot of inflammation, and the medicines work best the earlier we treat. But then once patients move into the secondary progressive phase, it's more a loss of brain tissue or neurodegeneration, and we don't have a lot of good treatment options. Over here on the right is looking at a course of primary progressive. Again, those patients don't have any defined relapses. A lot of times they may present to their primary care clinician reporting difficulties walking. They notice that they're dragging a leg, and they can't really identify when it started. Oh yeah, maybe a year ago this started, but it's gotten so bad that now I can only walk a couple blocks. Before I was able to walk 4 blocks. And again, the course can be variable, where there may be times where things sort of stabilize or the rate of progression may increase. Again, fortunately, primary progressive MS only occurs in roughly 10% of patients. And again, the treatment options are quite limited for patients with primary progressive MS as well. We really treat secondary progressive and primary progressive as the same. I feel like it's the same underlying disease process. And this is just another example. And I know it's a busy slide, but just to give you a sense of what potentially may occur. Again, showing a patient that's not on disease-modifying therapy, where in the red we have lots of inflammation early on. And then underlying that inflammation is neurodegeneration, which is represented by the purple line. And again, at some point here, this is where patients are really transitioning into that progressive disease. They're not having any further relapses. And usually in patients with progressive disease, we do not see new MRI changes. Again, the white matter changes are due to inflammation. And really what's occurring is that there's loss of brain tissue or atrophy, both in the brain but also in the spinal cord, and that's very difficult to measure on conventional MRI. And then on the yellow, you can see is that patients have more difficulties. Again, there's spikes here correlating with their relapses, which fortunately for most patients, when they have a relapse, they will get better. But over time, the disability continues to add up. So how is a diagnosis of MS made? Mostly based on history, and it's so important to try to identify previous symptoms. What are the current symptoms? Again, family history may also be helpful. And then a physical exam. There are certain findings on exam which may be suspicious for multiple sclerosis. To be honest, there's really no specific laboratory testing. So your clinician may order some blood work to rule out other conditions, such as a lack of vitamin B12. A lot of times clinicians will do a screening test for lupus, which will also include other autoimmune disorders. But the MRI is the most helpful, and that will identify if there's been any areas of inflammation. And then sometimes patients will undergo a spinal tap or a CSF examination, and that's not always needed. So I think that if, in my practice, if the clinical symptoms or history is consistent with MS as well, the MRI typically don't do a spinal tap. There's not one specific test that confirms a diagnosis of MS in the spinal fluid. About 85 to 90% of patients will have some inflammatory markers which are elevated or present. So that's called the IgG index or oligoclonal bands, and that's just evidence that there's been inflammation in the spinal fluid. But even if those are positive, those are not specific for MS. So just because you have those, that doesn't mean you have MS. And if they're negative, it doesn't mean you don't have MS. So I think I typically will have patients undergo a spinal tap if we're unclear about the diagnosis. And there's something called evoked potentials, which can potentially also help make a diagnosis. Those are rarely done now. The most common is called visual evoked potentials, where patients will look at a checkerboard pattern and there are electrodes that are hooked up to their head that monitor how their eye is picking up that pattern and the signal, how it's traveling all the way back into the brain. And so you can identify if there's been some damage to the optic nerve as the signal will move slower through those areas. So sometimes that can be helpful in making a diagnosis, but typically it's not a routine test. So with MRIs, we look for areas of damage, which these terms are used interchangeably in terms of lesions or plaques. And there are two main types of images that we look at. One is called T1 weighted scans, which is with a gadolinium or contrast. And that's really best at identifying lesions that are new within the last 4 to 6 weeks. We're really not going to help see the other lesions. So in my patients that are newly diagnosed, yes, I like to give gadolinium or when we make a change in therapy. But for patients that are doing well on treatment, sort of phase out giving the gadolinium because they're doing well. It's unlikely that they're going to have a relapse or a new enhancing lesion. The other sequence is the T2 weighted scans, and that evaluates the number and size of lesions, and that's the scar tissue. And so we can't date we can't determine how long those lesions have been there unless you have a previous MRI to compare. So this is looking at a couple MRIs of the brain. So the one on the left is a patient has received the gadolinium or the contrast, and the one on the right is the T2 or flare image. So this is the back of the head, and the patient's looking up. And all this is the cerebrum, the main part of the brain. And as you can see, there are two fairly large lesions, but there's also several smaller lesions that are scattered throughout here. And especially these are very classic MS appearing lesions. And again, we can't date how old they are, except maybe with contrast. And you can see on the image on the left, this lesion is slightly taking up the contrast, and so this lesion is likely new within the last 4 to 6 weeks, while the other ones, again, who knows how long they've been there. They could have been there for maybe 3 months or 3 years or even 10 years. And again, unless there's a previous film, we're not able to determine when they formed. This is another example of an MRI brain. This is looking at the head from the side. So just to orient you, we can see maybe the lips. This is the sinus, the maxillary sinus, and the tongue. And then we can see maybe a muscle to the eye. And then all this here is the cerebrum, the main part of the brain. And then here is your cerebellum, the balance center. And then all the white here is where there's been inflammation, which has resulted in plaques or lesions. And these are very consistent with MS. MS lesions like to be next to the ventricles. The black part is the ventricle. And they also like to be perpendicular to the ventricles. This is a very typical example of a patient with MS. Imaging of the spine is quite challenging because the spinal cord is very small. And as you can see, this is the spinal cord here. This is in the thoracic spine. And then the white surrounding it is the spinal canal. These are the vertebral bodies, and in between those are the disc. And in this, because the spine is so small that usually if you develop a new lesion in the spine, you're going to have new symptoms. So for this reason, we don't always repeat imaging of the spine unless there's been a change clinically or potentially some changes on exam. The image over here is as if we sort of cut the spine through, straight this way. And then here's the spinal cord, and then this is an MS lesion. So again, it's quite small and maybe even more challenging to see on this video. And then up here are the lungs. So usually lesions in the spine result in more symptoms because again, it's so small, and then the spine is not able to re-network like the brain can. It's also important to remember that not all white matter changes are due to MS. So it's not uncommon where I might see a patient who has a history of headaches, and then their clinician ordered an MRI, and the MRI shows some white matter changes, and then they're being referred for MS. So really to have a diagnosis of MS, you need to have clinical symptoms consistent with MS, and we don't think of headaches as being a symptom associated with MS directly. But as we get older, we start to develop some of the white matter changes in those sort of aging spots. People with migraines potentially may have white matter changes, and those that have high blood pressure or diabetes or smoked are more likely to develop white matter changes as well. And that said, it's really important to make sure that you have a good primary care clinician that's addressing some of these issues because we know that patients that have high blood pressure and diabetes are more likely to develop progressive MS. And also, if you're smoking, one of the best things you can do for your MS is to stop smoking because, again, those patients who smoke are at higher risk of transitioning to the progressive form of the disease. In terms of treatment, so if a patient develops a new symptom that's consistent with a relapse, let's say a patient calls our office and says, all of a sudden I'm starting to see double and I have some numbness on my face, likely would be consistent with a relapse. And then we would treat typically with steroids, IV solumedrol. And depending on the severity, sometimes we would just do 3 days. Let's say if it's relapse is more severe, there's inflammation in the spine that's really affecting walking, then we may extend that to 5 days. And sometimes we may need to repeat the course depending on if the symptoms are still present or have not improved. And then we can focus treatment also on symptoms. So if someone's experiencing spasms, physical therapy potentially may be beneficial. Looking into things like yoga, or just doing some basic stretching at home can help with spasticity. It's common for MS patients to have tightness in the hamstrings. And unfortunately, a lot of times the spasticity can be more severe at night. Supplements such as a B complex or magnesium can help relax the muscles, but there are also some prescription medications for spasticity, including baclofen and Xanaflex, but one of the potential side effects is drowsiness. So with all of these potential symptoms, there are some things that can be done, or there's some treatment that potentially may be beneficial for these symptoms. And again, it's a balancing act because a lot of medications can cause drowsiness, and already fatigue is a potential side effect. And we talked about some things that can contribute to fatigue. And so a lot of times we'll sort of look at sleep and is there underlying maybe sleep disorder. So sleep apnea is more common in MS patients, and so frequently I'll refer patients to see a sleep specialist to undergo a sleep study. So moving on to disease-modifying therapy. So when we look at patients who have relapsing disease, we want to get them started on treatment as early as possible to reduce relapses. which also the treatment will help reduce MRI changes and then also delay disability progression. And we know that the earlier we start treatment, the better patients do. And there have been multiple studies that have shown this outcome. And it's really the same thing with patients with primary progressive. While many of these medicines have not been shown to be effective for primary progressive, we do like to, once a diagnosis is made of primary progressive, is have a discussion about starting therapy. And I'll talk about a couple of those agents which potentially might be beneficial when we review the disease-modifying therapy. This is just a diagram of just showing the importance of early intervention. Is that that may halt any further relapses or disability versus patients that are not on treatment are more likely to need some type of assistive device. And we see that patients that were maybe diagnosed in the 1980s prior to disease-modifying therapy. So I'm going to briefly go over the current treatments that are available, but I'm not really going to talk about them in much detail. You can discuss this with your clinician. This is, again, a separate talk in itself, going through these each individually. But there are different treatment options for patients with relapsing MS. Sort of the initial agents that were approved, first one was in 1993, which was interferon beta, which was beta seron. These medications are still used, although typically there are medicines that are lower efficacy, although they are relatively safe. So we have glatiramer acetate, which is Copaxone, and then the interferon beta, there are 4 to 5 of those, and the frequency of these injections varies, with Plegridy being the least frequent injection every 2 weeks. And then there are some formulations of glatiramer acetate that are daily, but there's also another formulation that is taken 3 times a week. And then the other injection that is relatively new, which just was approved in August of 2020, is called Kesimpta or Ofatumumab. And this is very similar to an IV infusion called Ocrelizumab. And this is a subcutaneous injection. There is a period where you ramp up, where you have some weekly injections, but then it's a monthly injection thereafter. And then there are also several oral medications. And so there's a whole class called fumarates, and the one that you may be most familiar with is Tecfidera. And there is now a generic formulation of Tecfidera. There are a couple cousins to Tecfidera. One is called Vumerity, and the other one is called Befetarium. And these are all taken twice a day. And they're all broken down or metabolized to monomethyl furamate. It's possible that Vumerity may be better tolerated compared to its cousin Tecfidera with less stomach issues. And then there's teriflunomide, which is Aubagio, and that's only taken once a day. Cladribine, which is Mavenclad, and this is medicine that's there to help reset the immune system. And so there are 2 courses that consist of 2 cycles. So it's very convenient. Most patients will take 1 or 2 pills once a day for 5 days. They will repeat the same thing a month later, and then repeat the same thing a year later, with the hope that they may not need to be on any further treatment. If a patient should have a relapse or any MRI changes, potentially may need to go on therapy again, but would likely be put on different therapy besides Mavenclad. And then there is these agents called S1p medications, which affect the subset of white cells. They trap the white cells within the lymph nodes, so there's less of these cells circulating to cause havoc. And now there are 4 of them in the category, and they all have some different properties and require a little bit of different workup, and some may interact with medications, but they're all taken once a day. And then lastly, there are infusions. Natalizumab or Tysabri is given every 4 weeks, and patients are at an infusion center for roughly 2 to 3 hours. And then alemtuzumab, which is Limtrada. This is sort of similar in Mavenclad in terms of resetting the immune system. So patients are given an IV infusion for 5 days, and then a year later, 3 additional doses. And potentially, if a patient have a relapse, then you are offered treatment again. Ocrelizumab is another infusion that's given every 6 months, although the first dose is split into half. You go in, and then 2 weeks later, you go in for the second dose. And these infusions are longer, so for the most part, you're going to be at an infusion center for about 5 to 6 hours. This is the only treatment that's approved for patients with primary progressive MS. So if I see a patient with primary progressive MS, it's typically treatment that we would offer for those patients. So as you can see, the number of options are quite limited for our progressive patients. And unfortunately, a lot of these medicines that we use for patients with who have relapsing MS, these have not been shown to be effective for patients with primary progressive. One thing I do want to mention is something called progressive multifocal leukoencephalopathy, or PML. Most MS patients are familiar with PML, and this is a brain infection that can actually occur in anyone. The risk is roughly 1 in a million. However, if your immune system's altered, then potentially you're at higher risk for developing this type of infection. However, you do need to have the JC virus, and we don't know how the virus is transmitted, most likely respiratory, since it's quite common. About 50 to 65% of adults have the virus, and the older you are, the more likely you've been exposed to it, and it's not associated with any symptoms at all. And the virus lays dormant, or it's quiet in the body. However, when you're on certain medications, that virus, for unclear reasons, starts to circulate in the blood, and then potentially may cross over into the brain and cause inflammation, which we then term PML. These symptoms typically evolve much more slowly than an MS relapse, so over a course of days or weeks, and can be associated with really any neurological symptoms, including weakness or loss of vision or memory problems. And the way to distinguish between an MS relapse and an MRI and PML is by doing an MRI. And then a lot of times we would do a spinal fluid examination to check for the virus in the spinal fluid. So for patients that are on certain medications, particularly natalizumab or Tysabri, which carries the highest risk of the development of PML, we do check antibodies to the JC virus, and your clinician may also check that if you're on other medications, particularly the S1p medications or possibly Tecfidera or Vumerity. Those carry also a risk, but much lower than Tysabri and natalizumab. I spend a lot of time talking about PML with my patients, but again, this is something that's not very common. And while we have quite a large MS center here, we've only had 1 case of PML, which occurred almost 10 years ago. And this is an MRI with a patient with PML. As you can see, it's different than MS lesion. The white matter changes are much more prominent and confluent. You don't see sort of defined lesions or plaques. Unfortunately, PML can be fatal, and most patients can have some residual symptoms. Although the earlier you catch it, the more likely patients will have a better prognosis. So how do we decide between all these treatment options? And when I see a patient, a lot of times I like to have a joint discussion and give maybe 3 or 4 options that I think that would be a best fit. And especially if a patient has a lot of white matter changes or involvement of their spine, we typically lean more to using a higher efficacious medication. And then a lot of times would be our infusions and maybe some of the oral medications and the injection Kesimpta. A lot of it's really up to the patient. Are there other medical conditions? So For example, if someone has Crohn's disease, Tysabri can work both for Crohn's disease and MS. For rheumatoid arthritis, something like Ocrelizumab may work for both of those disorders. And sometimes insurance plays some role, but typically what I like to do is to ignore that, at least at the beginning, and we have a discussion about what we would like to do, and then we move forward with that, and then we see what insurance, how insurance decides in terms of coverage. And a lot of the pharmaceutical companies also provide support. So even if an insurance company denies medication, sometimes pharmaceutical companies will provide coverage at least for the first year while we're working on appeal and getting a medication approved. And everyone's different. Some people are prefer to go on a pill. Others say, I'm not used to taking medications. I know that I'm gonna have a hard time taking a pill every day. And then we may look at infusion options, which are definitely less frequent. So lots of variables come into play. And some people are reluctant to start treatment, and I completely understand, especially for our younger patients or people that are doing quite well, and want to continue working with those patients, and we follow them closely by coming in and doing exams and MRIs. But again, early on, there's a lot of inflammation where we can have the most impact, and so maybe some reasons is maybe patients don't have any symptoms, but while maybe you're not having any symptoms, there could be some changes that are ongoing in the brain that sometimes are picked up on the MRI and sometimes are not. Cost of medication, but again, a lot of companies have support programs. One reason, and this used to be several years ago, was needles. A lot of times the only option we had were injectables, but now we have lots of oral medication options, and then also side effects or safety. But it's also, I think, important to make sure, keep things in perspective and looking at overall benefits versus risk. So besides medications, it's important to focus on having a healthy lifestyle. And right now, there's not one specific diet that has been shown to be beneficial for MS patients, although there's a lot of studies looking at that and potentially how food may play a role in your microbiome, the bacteria that's in your gut. And so potentially reducing saturated fat, possibly reducing salt may be beneficial. And I think following a Mediterranean-based diet, and that's going to also reduce your risk of developing other conditions like high blood pressure or diabetes. There has been a small study looking at the paleo diet, although it had there was no positive impact in terms of reducing relapses and MRI changes, but people felt overall better. I mean, I've had some patients that have also eliminated sugar and they've noticed improvement in their symptoms, particularly muscle pain and muscle spasticity. So I think everyone is different, and I think the key is to listen to your body and to make changes slowly. So, if you are eating a lot of fast food, maybe that may be one thing to start to eliminate. And then you can make further changes after that. We've already talked about smoking. So if you are smoking, please stop. It's just, obviously it's not good for your overall health, but you're more likely to develop progressive MS. And alcohol, that would be something to discuss with your clinician, especially it may interact with certain medications. Obviously, if you're already having balance issues, adding some alcohol is not good. And then supplements, really the only thing that's been shown to be beneficial at this stage is vitamin D, although potentially adding fish oil or omega-3 fatty acids may work as an anti-inflammatory agent or antioxidant. And there has been a small study looking at alpha lipoic acid, and that was shown to maybe reduce brain atrophy or loss of brain volume in patients with progressive MS, and the larger study is ongoing. Just be aware of, if you decide to take this, that it can cause some stomach issues. Exercise is extremely important. So the more active you are, you build up a reserve. And so if something happens, your body is able to adjust or compensate better. For everyone, that's the type of exercise is going to be different. So some of my patients can still run. For others, that's not possible. So going for walks or swimming, although obviously that's limited right now with the COVID-19 pandemic. Yoga, I think, it can potentially be a great exercise for, I don't know if I list it as an exercise, but would definitely can help with balance and strength, and also help you be more aware of your body and focus on your breath, and can potentially be very beneficial for stress reduction, which again, stress may play some role in MS, because if you're stressed, your immune system is in overdrive. And looking at integrative care, so those would be things like massage therapy and acupuncture, may also potentially be beneficial for some symptoms, especially if there's some muscle pain or spasms. So what is on the horizon? So there are a lot of clinical trials that are ongoing. And if you want to learn more about MS trials, you can always go to a website called clinicaltrials.gov. And there are studies looking at repair or remyelinating agents, and we've participated in a couple of those recently here at the MS Center, although unfortunately they were shown not to be effective, but likely there's going to be further ones. Stem cell transplant, there have been some small studies looking at resetting the immune system with stem cells, and a larger study is being planned, although my understanding is that is on hold right now because of the pandemic and the risk of infection. But also stem cells may be beneficial for repair. So so stay tuned. This may be a treatment option in terms of helping improve symptoms. So we have ways to evaluate how patients are doing, both by doing a clinical exam and an MRI, but there is a blood test called neurofilament, and there have been a lot of studies that suggest that this is very beneficial to follow. So patients that have high neurofilament levels, which suggests there's been some breakdown in the brain, are more likely to have progression or relapses. So if we put a patient on medication and the neurofilament levels continue and may elevate it, potentially maybe that may not be the right medication. So might be able to be more proactive in making a change before someone has a relapse or an MRI change. And hopefully this blood test will be available in the near future. Part of the reason why it's not available yet is the cost, that it's quite expensive. Obviously, we lack in terms of treatment for progressive MS, and there are studies looking at other treatment options. And then just personalizing treatment. So this may be able to use some genetic factors that we may be able to identify that if someone has this type of genetic makeup, they're going to respond better to medication X versus medication Y. And right now we're not there, but I think that we will get there in the next few years. So at the Providence MS Center, we are a Center for Comprehensive MS Care and a partner in MS Care. We have 4 physicians, including myself, as well as Dr. Cohan, Dr. Brink, and Dr. Lupu. And then we also have the Agata here, a nurse practitioner. And we have an extensive research program here, and we participate in many clinical trials. We've been part of many medications that have been approved, including Ocrelizumab and Kesimpta, some of the most recent approved medications. We do have an MS support group that's led by our nurse practitioner, Leah Gatteke, that does meet the first Thursday of each month from noon to 1. And if you want to learn more information about that, you can contact Nora Perry, and her email address, I'm sorry we did not put that on here, is nora.perry@providence.org. So that can be very helpful for patients as well as family and friends who have of MS patients. And then here are some other resources. So the Multiple Sclerosis Association of America, they provide a research update yearly, which you can access through their website. And then the National MS Society has a great website. There's more information concerning symptoms. They go extensively through the disease-modifying therapies, and also during pandemic have been very helpful of updating that as well. And there's the website for the clinical trials, and then we also have our website for the Providence MS Center, and we do publish a newsletter twice a year. So I would like to thank you for joining me, and wish you the best of luck, and take care. Thank you.